pathophysiology.
So I'm going to talk a bit about the pathophysiology of the menstrual cycle. We do know that normal menstruation is regulated by the HPO axis. And then the follicular phase, which is the beginning of the menstrual cycle, all the hormones at that stage are low. Then, due to stimulation of FSH stimulation, the estrogen level starts going up. So does the LH, going towards the ovulation period, whereby the LH goes up and then there's an LH surge, then resulting in ovulation. So what happens there is that the endometrium thickens and the endometrial glands also increase. Then ovulation sets in. Then the remaining corpus luteum, that would be now, if pregnancy occurs or conception occurs, we'll get progesterone. But if nothing then happens, the estrogen level decreases and leading to endometrial shedding, which now begins the next cycle of menstruation. Next cycle, next slide.
Yeah.
So I'm going to talk a bit about abnormal uterine bleeding. I'm going to focus here on the non-pregnant women. So there is a mnemonic that is commonly used called palm coin. So palm coin, the P is for polyps, which can occur in the age-bearing group or perimenopausal and postmenopausal bleeding. Even in children, sometimes they can have polyps. They are not cancerous, they are benign, but it's one of the causes of bleeding in women. Then we've got adenomyosis and leiomyoma, which is the same group. So the adenomyosis is it's also fibroids, but it's more or less your glands which are within the myometrium that cause a globular uterus that we usually see with adenomyosis. Then leiomyoma is the fibroids as we know them. And then other causes of bleeding are malignancy, especially in gynecology, we're looking at cervical cancer and endometrial cancer causing bleeding. Then we've got coagulopathies. Coagulopathies mostly would be these women who come bleeding with menorrhea, but we cannot find the cause. Then we start moving towards medical causes of the bleeding. So an example would be von Willebrand's disease and thrombocytopenias and other coagulopathies, and also a history of hemophilia, although we do know that in women are carriers rather than being affected by hemophilia. Okay, then we move to more ovulatory causes. So ovulatory causes would be mostly caused by hormonal medication, especially contraception-wise in women, and with the women who are not non-compliant, or probably even if it's women who are compliant. If you use a hormonal, let's say, injection contraception like Depo, it tends to start causing intermenstrual bleeding somewhere in, just in between, or something like Implanon, also progestation only hormonal medication can cause bleeding in between, intermenstrual and withdrawal bleeding as well. Ovarian patients with ovarian masses don't really present with bleeding, but we do put it in the palm coin. Then we've got endometrial problems as well. These are endometrial shedding or endometrial thinning, which happens irregularly without following the proper cycle of menstruation. So we also need to look at that. Then we've got the ones that are then unknown or none otherwise specified. And I've included trauma here as well because it can cause vaginal bleeding. We're moving to the next slide, Prof.
Yes.
So in this slide, I'm looking at the young girls, premenstrual children, including neonates. So in neonates, you can have issues of endometrial withdrawal, okay, which is from the hyperestrogenic state of the mom. So sometimes neonates can present with PV bleeding. Okay, then in the older girls, we know that they can start sometimes, if they've got precocious puberty, they can start bleeding earlier. So we need to also investigate that. Other causes could be medical in this group, where it's probably due to infection or inflammation, probably vaginitis or even tumors in the young. And also you can have your sarcomas that can cause PV bleeding. Okay, then trauma, straddle injuries, when kids are playing on bicycles and all that, they can sort of fall and injure the genitalia and have PV bleeding. And then the issue of foreign body also, it's easy for kids when they're playing to just probably put something vaginally, which can then irritate them and cause bleeding. Next slide.
Okay.
So now here we're looking at women of childbearing age. So I focus more on menorrhea here to say menorrhea is a heavy menstrual bleeding, which is cyclical, whereby the HPO axis is intact, and it's commonly secondary to endocrine problems. For example, thyroid is one of those that can also affect the sort of female organs and cause a bleeding in terms of endocrine problems. Then we've got von Willebrand's disease, which I have already mentioned, and bleeding abnormalities, and some medications that are used, especially hormonal medication. Then there's menorrhea, which is a menstrual bleeding, which is acyclical, and the HPO axis here is deranged, which leads to failure of ovulation. So common causes also medical issues like diabetes, and then in females who have got PCOS, it's a problem. Then prolactin issues, weight issues, eating disorder, anorexia, and then psychiatric medication. Most of the time, psychiatric medication needs to sort of causes amenorrhea, but sometimes it can start as abnormal uterine bleeding, and then we need to investigate it, of course, and malignancies as well. Next slide.
Yes.
Are you still there, Prof?
Yes, bleeding in pregnancy.
Okay. So bleeding in pregnancy, yes. So with bleeding in pregnancy, we know it shouldn't happen, but at the same time, we do know that it's common. And it's very common. I mean, it affects about 1 in 3 of pregnancies. And with this, it depends on the trimesters of pregnancies and viability. So causes in the first trimester of pregnancy, which is up to 13 weeks of pregnancy, a patient can have implantation bleeding, which is due to the fertilized ovum being implanted into the endometrial lining. But this would probably be spotting that should then stop and the pregnancy progresses. Then the issue of miscarriages. You can have miscarriages, spontaneous miscarriages, either sporadic or recurrent, which we see often in the clinics. And these are patients that always present at the primary healthcare setting. Then ectopic pregnancy, because of the endometrial shedding, even though in ectopic pregnancy also the patients might not bleed, but some would spot or bleed a little bit because the endometrium is shedding. Then you can have a subchorionic hemorrhage, trauma, and also medication that can cause bleeding in pregnancy if the patient was not counseled properly about which medications to take and which ones not to take in pregnancy. So this is early pregnancy. Then we move to the second trimester. Next slide.
Yes.
So in this group, still it's miscarriages, okay, which can be induced, unsafe abortions that people do out there, and also therapeutic if maybe there is medical indication for us to terminate the patient as well. So in terms of second trimester miscarriages also, we've got threatened miscarriages, inevitable, incomplete, missed, uncomplicated, and also septic miscarriages, which I will discuss later. Then also there's issues of anticoagulation. So this is basically, I was looking at our patients that are on anticoagulants, like for instance, cardiac patients who have got valves or metallic valves as an example, and that are on warfarin, so they are at risk obviously for losses of these pregnancies and also for miscarriages. So that's how I put this one in. And trauma also can cause bleeding in the second trimester. Then in the third trimester, these are viable pregnancies now, where the terminology changes and we call it antipartum hemorrhage. So you can have antipartum hemorrhage of unknown origin, okay, where you're going to then do an ultrasound to look at placental location and exclude the cause. In that case, depending on how much the patient is bleeding, if it's not a flood and it's just spotting, then you don't need to do anything on this patient. If by ultrasound and NST, everything is under control, but you admit the patient to observe the patient until the bleeding has stopped. But we've got then the group of patients that we see who come with abruptio placenta, where we know that it is separation of the placenta from the uterus, and which causes bleeding, heavy bleeding. And there's also patients who present with placenta previa. If identified earlier in pregnancy, then we plan for an elective delivery of these patients. There is placenta previa, placenta accreta, and placenta percreta. But it would happen that it's a patient that maybe that is unbooked and just presents in labor with bleeding. Then you find that then it becomes an emergency and we need to go and do a cesarean section immediately on these patients. Then sexual intercourse in pregnancy can also cause spotting, not really bleeding, but a bit of spotting that stops, after you've observed the patient for about 48 to 72 hours. And trauma as well in pregnancy can cause bleeding. Next slide.
Okay. Next. Done.
So as we continue with the abnormal uterine bleeding, so here I focused on the perimenopause, menopause, and postmenopause. So in this group, menorrhea is common as women approach menopause. So the causes, it could be just normal processes, normal physiology of a woman approaching menopause, where they would on 1 month menstruate and on the next month not menstruate as we go along, and also start having irregular bleeding, but not necessarily heavy. Okay, then you can have other causes like atrophic vaginitis. And of course, we can have medical disorders, for example, thyroid disease and bleeding dyscrasias. Then of importance always is malignancy in this group. So we have to always watch out for that and counsel patients properly and screen for cancers in this age group. Then there's also infection, endometritis, cervicitis, and vaginitis. Okay, next slide.
Diagnostic approach.
Am I fine, Prof? I'm not going too fast.
Yes, you're going fine.
Okay.
Diagnostic approach, I'm on that slide.
Then, so diagnostic approach. So diagnostic approach, history is very important on all the patients we see, irrespective of what they present with. Then we need to do a physical examination. We need to do side room investigations, laboratory investigations, do imaging, and have a plan for treatment before referral of the patient. Or if there's probably there will be a need to refer, but if not, we should have covered all these that I've mentioned here. Okay, next slide. So in terms of the history, age at menarche, last normal menstrual period, important. You want to know about the cycle length of the period, the frequency, the duration, and the amount of bleeding. So we need to inquire about menstrual pattern changes. So menstrual pattern changes, it's the very group that I spoke about. For example, the perimenopausal and menopausal, where there is a pattern change indeed as women move into the space of their life. Also, you can have young girls who start menstruating, but then it stops, which are anovulatory. So you need to inquire about that. Okay, then there's a need to describe the menstrual abnormality. That is, if there is oligomenorrhea or polymenorrhea or intermenstrual bleeding, and also issues of dysmenorrhea have got to be attended to. Okay, then it's important that the menstrual calendar is used to record bleeding episodes. Then also we need to find out if this is chronic or if it's acute. So if it's been occurring in the past 6 months, then we know that it's chronic PV bleeding. And if it's obviously happening less than that, then we know it's acute. Then also we need to inquire about the menstrual products used, whether they use sanitary pads or tampons, and the frequency of changes. And also this is important in terms of the amounts, because some patients might tell you that they are not heavy bleeders just because they change frequently, but some, maybe who do not change their sanitary pads frequently then would be aware in terms of amounts of bleeding. Then we need to know the presence of clots, we need to know the size, and I've added here that also the importance of doing a pap smear and a Z sample. Sorry, I didn't put it here. I think we have to do that as well. Counsel the patients, and then we do that pap smear and Z sample. I'm moving on.
Yeah. History in children.
Yeah, so history in children, we need to look for signs of early puberty, breast development, hair distribution, weight gain, then weight loss as well, and polyuria in terms of probably endocrine issues like diabetes, maybe your type 1 diabetes, which is genetic as well. Then menarche is important, trauma, as I've mentioned, and history of sexual abuse is now, in this day and age, something that we cannot ignore and need to ask about. Okay, next slide. So past medical history, I just made it simple in terms of how we know how to take, in terms of how we take medical history in our patients. So I included the mnemonic DEARTH. In addition to that, we need to look at issues of anemia, symptomatic anemia, hematological problems, or renal disease, and current or recent medications that are used.
Do you want to spell out what DEART means?
Okay, so D for diabetes and E for epilepsy. We need to find out if the child is or the patient is epileptic and what medication they are on. If they are asthmatic, including the medication they are on. And with the A, I also include anemia in the A, because we see a lot of that in gynae. So we need to then investigate the cause of the anemia. Then rheumatic diseases, I think the R stands for that. We need to, and also, what are they called? Rheumatic diseases and connective tissue diseases included. We need to find out about that. Then we've got issues of TB, thyroid issues included in the T, and then H for hypertension. So with time, I tend to say a mnemonic can be a whole lot of things that we want it to be. We're taught that it's just what it is, but you can always add in terms of the alphabet and what you can add to it.
Sure.
Okay, yes, yeah. Then sexual history.
Hang on a second.
Prof?
Dr. Motlatsi just came in a second.
Yes.
If you have any questions, I see one question's already popped up. If you don't mind, please put your questions on it to the audience. Put your questions up. We've got about 70 people attending. But just to tell them so that they start putting questions out for you.
Okay, so Prof, what I want to know is that as they put the questions, are you going to be letting me know what the question is? Because now I can't see.
Not a problem. I'll read them out to you.
Okay.
Great. You can carry on from the sexual history.
Okay, so sexual history of contraception is important, or condom use, number of partners, menarche as already mentioned, coitarchy, especially coitarchy, history of sexually transmitted infections or current symptoms, e.g. vaginal discharge and pelvic pain. I think in terms of this, there's also the issue of HPV, which is important, and our society doesn't really know about it. So I think it's upon us to be able to teach them more about HPV, what it is, the vaccination, and what to do beyond that, and at primary healthcare level. Then we need to ask about previous pregnancies or termination of pregnancy. Next slide.
Okay.
So past surgical history. I've sort of simplified it, but I can expatiate on it. So I looked at the obstetric history. Of course, you want to know about previous cesarean sections that the patient could have had, or even including maybe a hysterotomy, although hysterotomy would be gynecological. And then in gynae, we want to know previous procedures done, if a patient has had an evacuation of the uterus, if she's had an ectopic pregnancy, if she has been treated for a PID before, where we had to go and do a laparotomy in theater, if there's been any pre-malignant lesions or query-malignancy procedures that we have done on the patient. Then we've got non-gynecological, which would be your general surgical procedures that a patient could have done, including probably orthopedic procedures. Okay, then we move on to family history. So family history, we'd be looking at bleeding disorders in the family, menstrual disorders, issues of chronic disease like diabetes, thyroid, and malignancies. Then social history, smoking, alcohol consumption, substance use, social stressors to the patient, and exercise pattern and athletic competitiveness. Okay, next slide, Prof.
Examination.
Yes, physical examination. So here I just made it basic in terms of the first person that sees the patient, let's say in GOPD. So the patient comes in complaining of what they're complaining about. Then before we start the examination, obviously we need to check the vital signs. Very important to know what the PP is, the respiratory rate, the heart rate, and the temperature. If the patient, for instance, is hypotensive and tachycardic, this may signal high hemodynamic instability and the need for intervention or resuscitation. And then also, in addition to that, if the patient is pale and maybe there's a presence of a heart murmur, it might suggest anemia. So obviously then it would mean we need to act swiftly in terms of treating the patient. Then you need to look at skin changes, bruising, petechiae, and which may suggest bleeding disorders, or if there's a platelet defect. And then a complete physical examination has got to be done of the thyroid, chest, cardiovascular system, abdomen, genitalia, and lower limbs. Okay, I'm going to expatiate on that in the next slide. Okay, so in the next slide, examination, we do a head-to-toe examination. I started more or less with the thyroid because it's a hormone that is, in terms of your pituitary, it's a hormone that is shared with the beta HCG. For example, in patients who have got molar pregnancy, in terms of presentation, you find that because their quantitative beta HCG is very high, then their thyroid function test also will be high, and these patients might have a thyroid storm on the table in terms of when you go and do a suction curettage. So it's important that we know and we assess the thyroid. I've written here swelling, meaning you can also assess and you find that a patient has got a goiter. So obviously then it means an MDT is needed, MDT approach, for the patient to be then seen by the physicians and treat further. Then chest examination, as we know it, we look for bilateral entry, check if there's crackles or wheezes, or if maybe there's signs and symptoms of metastasis in terms of patients that have got malignancy. Cardiovascular system, we obviously listen to the heartbeat and then we listen for murmurs. We know that in patients with anemia, especially who have lost blood, we do get an ejection systolic murmur. Then it's going to assist us in terms of treatment for the patient. Then the abdomen. So the abdomen, we inspect for marks, we inspect for distension, for any visible blood vessels, for any discoloration. We then palpate for masses, organomegaly, hepatomegaly, splenomegaly, and lymphadenopathy as well. We palpate. Then most of all, in gynae, we look for masses. So masses, we're talking about a multifibroid uterus or probably an ovarian mass. And we know that patients who present with ovarian malignancy or pre-malignancy, most of them would also have ascites. So then that's when we're going to then percuss, do a fluid drill and confirm ascites. Then from there, we need to examine the genitalia. So in terms of genitalia, we look at the vulva for lesions, pigmentation, PV discharge. Then we need to perform a digital examination, vaginal examination, and pass a speculum. In this case, we're looking at the cervix and we're looking for lesions, we're looking for lacerations, we're looking for signs of maybe a prolapsed fibroid or even a prolapsed uterus as well, which also could be the reason for bleeding. And then inflammation and infection. For instance, a patient who on inspection with a speculum, you know that the cervix, which appears inflamed and strawberry colored, most of the time with a PV discharge, then you know we'd be dealing with a trichomonas vaginalis, then we need to treat. Okay, we move on, Prof.
Side room.
Okay, so investigations. So investigations, we start with the basic side room investigations. So every woman that presents to us, age 52 and less, maybe age 12 and more, we need to do a pregnancy test. And the reason why I'm saying 12 and more, we are seeing a lot of girls now that are falling pregnant early, and also issues of sexual abuse, you know, so and they won't be talking. Maybe they come with their issues, but they're scared to talk. So doing a urine dipsticks will assist in, excluding infections, but a urine beta HCG will assist us in excluding pregnancy. So then we do a urine dipsticks to exclude infection, look for leukocytes, cast, nitrites, pH, and then glucose as well. We need to check to exclude diabetes. Then we need to check for protein, especially in our hypertensive patients who present with preeclampsia. Those are the pregnant ones. Then HB assists in cases where it's not as easy to reach the lab. At least it will indicate to you what the HB is and the need to transfuse the patient at that point, plan to transfuse. A blood gas in hemodynamically unstable patients might be required as well, so that we know whether we need to, in terms of resuscitation and intubation. Then sonar, we usually start with a transabdominal sonar. So it's a side room imaging, transabdominal sonar, and then we move on to a transvaginal sonar if warranted. So here we're viewing the organs, we're looking at the uterus, we're looking at the fallopian tubes, ovaries for different pathologies, e.g. Your multifibroid uterus, you can see that on sonar. And patients with a pelvic inflammatory disease, grade 3 or 4, with a tubo-ovarian complexes, a sonar would also assist to identify that. Ectopic pregnancies, intrauterine pregnancies, of course, and ovarian pathology. We move to the next slide.
Lab investigations.
Yes, then lab investigations. Bleeding patients, I think it's important that we do an FBC. Do platelets with platelets and differential and a smear to exclude either anemia in terms of the HB, but also hematological problems in terms of doing the whole HB, which has got your MCV and MCH and MCH, all the others, including your RDW and your hematocrit. I think that is needed. Then we do a UNE to check for kidney function, and we look at the urine creatinine, and we also look at electrolytes, isn't it? We check for electrolyte imbalance. Okay, then we've got INR-PTT, which we do for checking for clotting factors. Then in this one, maybe we can add patients that are on Clexane, where we can actually check the anti-factor 10A if patients are on therapeutic Clexane for one reason or another. Then liver function tests, we need to check that, especially in patients that present with a bleeding due to malignancies. Then we qualitative beta HCG to confirm a pregnancy, for example, ectopic pregnancy or molar pregnancies and other pathologies like choriocarcinomas. And then we need to do blood for compatibility if the patient is going to warrant transfusion. Then iron studies are important in anemia patients, and a thyroid function test is very important, as I have mentioned, especially for molar pregnancy patients. then it's important to do a hormonal profile as well, just to check the FSH, LH, E2, prolactin, testosterone, sex hormone binding globulin, and other tests. Okay, then maybe what I did not include here, Prof, is a tumor markers. I think there's also a need to do tumor markers in patients, especially, let's say, for example, a patient who presents with ovarian problems, whether bleeding or not. I think it's important that we do SCA125, SEEA, and SCA 19.9. Okay, we move to the next slide.
Imaging.
Okay, so imaging, as we all know, basic on a patient that we see acutely, a chest X-ray will help. Then we do an ECG, and then in terms of the chest X-ray, remember with the resuscitation, sometimes we overload patients unaware. We're trying to sort of, assist the patient, but we also cause a pathology, and a pulmonary edema is what could emanate from giving too much fluid. So it is important to do a chest X-ray, and also to exclude all the lung pathologies that I've mentioned earlier. Then we need to do an ECG to exclude cardiac issues. And then once we have done a side room ultrasound, then it's important for us to get a formal ultrasound as well. And then if we're warranted with the malignancies, maybe checking for metastasis, then it would be advisable to do a CT scan. And then we also know that we can have patients that present with DVTs, malignancies again, mostly. So we need to do Dopplers so that we know if we need to start them on Clexane or warfarin. And then for the pregnant patients who are presenting with APH in terms of viability, then it's important to do a non-stress test or to do a cardiotochogram if that patient will be having contractions or in labor. Okay, we move to the next slide. Okay, so management and treatment. After an assessment and diagnosis is made for a patient with PV bleeding, treatment should be commenced without any waste of time. So in acute but stable patients, non-pregnant women, the whole group, childbearing age, perimenopausal, postmenopausal. In terms of medication, conservative management, medication, we give them tranexamic acid. So tranexamic acid is a tablet that assists in building a clot. So these women are bleeding, so basically we're trying to stop the bleeding. So we are usually the amount we give is about 500 milligrams TDS for about 5 days, or if maybe the patient is bleeding a lot, we give 1 gram per os TDS. But for those patients that we admit, then it would be advisable that we put them on IV medication at the same doses, and also observing for response. And then in other women that are, even if they're acute but stable, that you are not really going to be admitting, it's important that we talk to them about combined oral contraceptives, because we need to try and correct the bleeding in terms of the cycle. So we need to correct so that then their bleeding goes according to the menstrual cycle. Okay, these are temporary measures that we take, and then injectable contraceptives can also be used for this purpose temporarily. Then sort of chronically, we sometimes include IUDs for these women that are hormonal. An example I should have put in here is a Mirena that we use for those patients that, for instance, have got multifibroid uterus and are bleeding and have pain. But it's possible. When you do a SONA, it's not big fibroids, it's small fibroids. And it's possible to insert an IUD for them to minimize the bleeding and stop the bleeding. Then patients who are in their first or second trimester, these, you need to stabilize them first. Then in the Ringer's lactate, you can then put syntocinon, IVI, 1 liter of 1 liter of Ringer's lactate, because it's an oxytocin and it is going to assist in contracting the uterus. And then we should also not forget that these patients need to get analgesia. Then analgesia, we can give non-steroidals, anti-inflammatories, and then paracetamol or opioids. Okay, next slide.
Next.
Whew. Yeah. Next, it's okay, the acute and unstable patient. So this is our nightmare. You know, the others we can sort out very quick, it's fine. So this is a patient we definitely must not waste time on. We need a patient following the A, B, C, D, E as we know it. So airway, breathing, cardiovascular system. Apologies, Prof, I've forgotten what the D and E stand for. But yes, we need to follow this, okay, to resuscitate the patient. So airway, we need to administer oxygen for the patient, then for airway and breathing, and then cardiovascular. We need to insert 2 lines, IV lines on each hand, 16 gauge borehole. On the one line, we're going to give colloids. On the other line, we're going to give crystalloids. So, for example, the colloids we give are Voluven or Gelfusion while we are waiting for blood products. If it's a patient who's hemodynamically stable and probably is in shock, is hemodynamic shock. So we need to do that. Then crystalloids usually we use Ringer's lactate. Normal saline can be used in instances where there is no Ringer's lactate. Then we give cyclopentone IV. We need to start it so that we start reducing the bleeding. And then we also give syntocinon. If it's pregnancy related, we give syntocinon, about 20 to 40 milligrams IVI in a liter of Ringer's lactate, and run it at about 100, 120 mils per hour to contract the uterus. Then at this stage, we need to counsel the patient for further management, because these are patients that might need further intervention surgically. So counseling and consent comes in very handy. Then we also need to be talking to the anesthetists. It's more or less a multidisciplinary plan here. If the patient has got to go to, say, theater immediately, for example, for an evacuation of the uterus. Okay, next slide. I hope I've covered this one well.
Yeah, referrals.
Yes, so now indication for referrals to hospital. So your hemodynamically unstable patient, a patient presenting with hypotension, tachycardia, hemoglobin of less than 7. We have patients that we see with hemoglobins of 2 and with a very heavy bleeding. And you find that they are seen at the local clinic. That patient, you mustn't waste time on. They need to be referred. And then in addition to the treatment above that I have mentioned, the patient where you are struggling with medication to give at that time to control the bleeding, it's better to pack them as well. So you can pack them with acetone if you've got, or if not, you just take wet swabs and just pack and then give the fluids accordingly. And then you refer and transfer the patient to a level 3 or level 2 hospital if they will be able to take over management. And then we also advise that the patient that require IV medication rather be admitted, whether it's either a level 1, level 2, or level 3, depending on where the healthcare worker is seeing the patient at that time. Then obviously the patient that are going to need surgical intervention have got to be referred to hospital, be it manual vacuum aspiration. Of course, some centers, primary healthcare centers, do perform manual vacuum aspiration, but if it's got to be an evacuation of the uterus, then these patients will have to be referred to either a level 1, 2, or 3 hospital. And then obviously women that are pregnant and presenting with APH have got to be referred to hospital. And I think that's as far as I managed to get and prepare this topic, Prof.
Oh, well, thank you very much. It's been 55 minutes or 50 minutes plus, so that's a lot of time you've taken. So thank you. I know it's exhausting to go through such a comprehensive take on the question of PV bleeding. So we've got some questions. Thank you to those who provided. I'll just go through them. I hope that we can contextualize it. Dr. Vilakazi asks, what would you regard as an abnormal number of sanitary pads?
I think more than 5 is an abnormal number of sanitary pads. We've had patients that if they are really heavily bleeding, they tend to even move away from sanitary pads and start using the disposable nappies for babies. So I would say more than 5 is a lot. It's heavy bleeding because remember we're looking at between 10 and 80 mils of a normal menstrual cycle. So anything beyond 80 mils becomes heavy. But there are those who can really bleed.
Now, if I may ask, just adding to that question, is it, do you find it is challenging when you ask the patient to make the judgment, is this bleeding heavier than normal?
Yes, it's hard. It depends on the patient, maybe age group, you know. The childbearing going on, they might be able to answer, but the young girls, maybe it would be difficult for them. But what I find it easy for me is to ask how many sanitary pads or tampons are changed in a day. Then if you say in a day, they're able to answer. But if you say overall through your menstruation, then it's going to be difficult for them to give you an indication of how much.
And do blood clots in themselves, are they an indication that it's heavier bleeding than normal? Or can it be that it's quite normal?
The bigger blood clots, Prof, would be an indication that it's heavy. The small ones that are like streaks, those you wouldn't count because anyway, normal menstruation does come with some streaks of clots. Just your normal 3-day or 2-day menstruation can have that at the end of it. So, but if it's chunks and big clots, then that is not normal bleeding.
Yeah. So I hope Dr. Kelebocha, that answers your question. I think Dr. Vanka asked the question, endometriosis as a differential diagnosis. I'm not sure what he means, but would you consider PV bleeding as endometriosis as one of those in a non-pregnant patient, a childbearing age?
So the reason I didn't really include it is that patients with endometriosis present with pain more than they present with bleeding. Yeah, but it of course it is pain when during menstruation. You see, it is cyclical, but they don't get your dysmenorrhea, which is primary. Primary meaning the day before or maybe day 1. They get secondary dysmenorrhea, which is throughout the menstrual cycle or throughout the days of menstruation. But they do not have they just have normal menses, but with pain.
Okay, yes. Very useful, thank you. And then Dr. Belisha asked the question, what is the approach to dyspareunia with postcoital bleeding? I suppose
age group related.
Well, a 24-year-old.
A 24-year-old.
Dyspareunia. She's complaining of it with postcoital bleeding since her first encounter.
So we'd have to investigate further, Prof, for if there's maybe any masses that are causing an obstruction or things like constipation as well, you know, they could probably be the cause of the dyspareunia. But we don't regularly get dyspareunia in the very young girls, you know, in your 24-year-olds. But of course, we need to investigate further. And then there are non-menstrual dyspareunia, if I might say. Right. So these are issues that have got to do with some psychology in them. I've just forgotten the terminology, but you need to start investigating it in that manner, if maybe there are other issues that are causing that other than only the gynae issues.
Yeah,
yes.
Underlying psychological problem.
So, yes, okay. Yes.
I think with postcoital bleeding in a sort of 24-year-old, you'd be thinking of local infections.
Exactly. Local infections, foreign, if they're using foreign things also, sex toys. Oh, okay. Kind of thing, then maybe it could lead to that, a bit of trauma, if I might say. But dyspareunia in a 24-year-old, it could be there, but it's not common.
No, that's fine. Thank you. Dr. Killerboch also asked a question. I'm not sure what it means, bleeding while on long-term progesterone. So in other words, if you're on depot and bleed, it's actually usually stops bleeding. So if you're on long-term depot or any other progesterone implant, example, so it's not only progesterone, but anything long-term, does bleeding trouble? Do you get, what sort of bleeding challenges might you get?
We do get bleeding challenges, especially with the implant. It is progesterone. So these are progesterone-only contraceptives, long-term reversible, as we call them. So we do get problems of intermenstrual and withdrawal bleeding with these patients. Yeah, I think it's just the endometrial shedding. Sometimes with the implant I need to go further into searching the reason, Prof. But with the depot, I think sometimes it's got to do somewhere with compliance. Yeah, they're not injecting it exactly on the date in terms of your last injection. Then it starts causing an imbalance. It's a hormonal imbalance, basically.
That's right.
Yes.
You've mentioned a combined oral contraceptive. What would be the commonest, gynae problem with the adult childbearing age woman? If you were to sort of say young woman comes in, not pregnant, what would be number 1, 2, and 3 in terms of your differential? Commonest.
Who come with PV bleeding?
Yeah, come with PV bleeding.
Abnormal uterine bleeding or irregular. So you need to go back to the menstrual cycle and then figure out why the cycle is not regular. Then you go into medications. Yeah, what else could the patient be on? Maybe this patient is on antidepressants. Yeah, and then is also using on contraception as well. So then I think the interaction or efficacies, then it starts disrupting the contraceptive that she could be using and starts causing irregular menstruation.
Well, thank you. That's a very useful point. I think, in primary care, lots of the time we deal with relatively minor bleeding and not much complications. So thank you. That's very useful. Thank you, Dr. Mopapie.
Yeah, thank you, Prof. I'm very sorry that I couldn't properly log in. I feel like I need to do a better talk next time.
No,
where I can see
you're always welcome to come and speak in Joburg. And there's an audience of 71 people. I think they would. They've already shared. They've enjoyed it. Found it really great. Very amazing. So you've got lots of very good accolades. So thank you for your time.
Thank you very much, Prof. Thank you.
And thank you to the audience. Take care. Bye-bye. And
you too, Prof. Thank you.
Thank you. And the recording will be on the website. So please have a look at that. We'll see it again. Take care. Bye-bye. Enjoy.
Then I will send you my MP number.
Yes, please. Thank you.
Okay. Thank you. Thanks, Prof.
Thank you.
Okay, bye.
Take care, Dr. Mopapie. Thank you, everyone.